Good morning, everyone. I thank the AIOC for asking me to speak on this topic, and also thanks to SPOCI for asking me to speak on this subspecialty. I'll be presenting in small data of analysis of trochlear nerve palsies done at a clinical setting. Now the aim was to study the pattern of trochlear nerve palsy in clinical setting in central India, to know the clinical presentation and associated deviations in congenital and acquired palsies, and to assess the surgical results in patients who required surgical correction. Now, fourth nerve palsy we know is in commonest trochlear nerve palsy found in strabismic clinic. In children, the most category of fourth nerve palsy is congenital, and in adults, trauma and ischemia are the leading causes of fourth nerve involvement, and the other causes are infrequent. The commonest presentation of this condition is a hyperdeviation of the affected eye and abnormal head posture, including head tilt to the contralateral side, as in this case, who presented with left hypertropia had a head tilt to the right side. The superior oblique palsy, which remains there after 6 to 8 months, would require surgical correction. This was a retrospective analysis of patients of superior oblique palsy, both congenital and acquired, attending Drishti Eye Clinic and Squint Center between January 15 to December 2016. We analyzed 54 subjects, 12 were excluded as they were lost to follow-up. All the clinical assessment and surgeries were performed by single pediatric ophthalmologist. Vision, antisegment and fundus were examined in both the eyes. Fundus was also examined for torsion. Squint assessment was done, and presence of facial asymmetry and abnormal head postures were noted. The subjects were diagnosed based on clinical examination by the Parkes 3-step test, which we all know that the first thing we do is to see which eye is hypertropic, which reduces it to 4 muscles. Then we see in which direction is the vertical deviation more, which reduces it to 2 muscles. And then we see when the hyperdeviation increases on head tilt to the right or left shoulder, which brings it down to a single muscle. So in this example, it would be the left superior oblique muscle. If the hyperdeviation, left hypertropia increasing in right gaze and increasing on left head tilt. When one has to examine the extraocular movement, you can see in this video, there is no deviation in the left gaze, but in the right gaze, there is a hypertropia of the left eye, and there is an underaction of superior oblique muscle, and this increases in the left head tilt. The Hess charting gives an valuable assistance in knowing the position of the eyes, as in this case there is underaction of both the superior obliques asymmetric with overaction of the inferior obliques. So it's a case of bilateral superior oblique palsy. There is also an X-cyclodeviation. Then on table we do an exaggerated force junction test, that is we retropulse the globe in the orbit and see for the laxity of superior oblique tendon, which helps us in deciding the surgical option. So this is seen commonly in cases of congenital superior oblique palsies. The selection of operated muscle procedures were based on the recommendations, and the procedures chosen were, the most common was inferior oblique recession, the tucking of superior oblique, inferrectus recession, and Harada-Ito procedure. Here I would be showing a very small clip of the Harada-Ito procedure, because rest of the procedures it's not possible to show the clips. So in Harada-Ito, we know that there's a superior oblique has 2 components, anterior 1/3 for the intorsion and posterior 7/8 for the posterior 2/3 for the depression. So wherever there is in acquired palsies, there's a X-cyclodeviation. We want to weaken that portion of superior oblique. So the 1/3 portion, anterior 1/3 slip of posterior of the superior oblique muscle is dissected, and it is attached 8 millimeters behind the superior border of lateral rectus, which reduces the X cyclodeviation, and this can be also put on adjustable. Now the results of a study was there were about 40% females and 60% males. Age, when we saw it, was maximum cases were in 0 to 10 years, and a second peak was in 50 plus because they were the acquired cases. Etiologically, of the 42 cases, about 55 were acquired and 45 were congenital. Of the acquired, 60% were ischemic and about 40% were traumatic. We also had significant ocular deviations in cases of associated horizontal deviations in cases of congenital supraoblique palsy. About 37% had exotropia, equal number at esotropia, and pure vertical was seen in 32%. Examining the head tilt to the opposite side was seen in maximum, that is 60%, but head tilt to the same side also was seen in about 25% of cases, and chin up and down was seen in about 18% of cases. Recovery in acquired supraoblique palsy, about 70% recovered on their own. 22% required prism specs, and surgery was required in about 9% of cases. Of the 20 surgeries we did, 18 was for congenital and 2 were for acquired. 17 patients also required surgery for associated horizontal squints. Of the vertical muscles which we did for supraoblique, 55% required only one muscle surgery, that is most common muscle was inferior oblique. Just finishing off. 35% required 2 muscle, and 2%, that is 10%, required a 3 muscle surgery. So the post-op results were eyes were straight in about 64%, 33% there was a minimum deviation, and only one case we required a resurgery. So even the previous studies showed that the congenital palsies were 45 and 55% were acquired, and of the 23 acquired palsies in our case, 60% were ischemic, which was more or less similar incidence as the other studies. So this is all I've covered. So these are the pre-op photos of a case of acquired fourth nerve palsy. She had a small exotropia with right hypertropia and an significant X cyclodeviation, and here we did a right inferior oblique recession with Harada-Ito to a right supraoblique and right lateral rectus recession, which corrected her exotropia as well as her vertical deviation and X cyclodeviation. Now this is a case of congenital fourth nerve palsy showing a gross facial asymmetry with a right hypertropia and an overaction of right inferior oblique, and here just one muscle surgery, that is inferior oblique recession, corrected her hypertropia and head posture, though the facial asymmetry remains. So to conclude, trochlear nerve palsy presents a diagnostic difficulty to ophthalmologist not dealing with strabismus. Congenital and acquired were equal in our study. Spontaneous recovery was seen in about 60% cases of acquired palsy. Opposite head posture was seen in about 1/4 of patients. Surgical treatment was successful with only one patient requiring resurgery. Limitation of a study was small number of patients. And thanks for a patient listening.